Welcome to the Radiology Review Podcast, your on-the-go source for radiology education with your host, Dr. Matt Covington, a board-certified radiologist. Please follow the podcast on Twitter at RadRevPodcast. Send emails to theradiologyreview@gmail.com or visit the website theradiologyreview.com.
Welcome back to the Radiology Review Podcast. On this episode, I will present questions and discuss answers pertaining to renal imaging in nuclear medicine. This will be a multi-part series that will likely encompass either 2 or 3 episodes. Upon completion of these episodes on renal imaging in nuclear medicine, a study guide will be made available for free download at theradiologyreview.com. Without further ado, let's get into the questions and answers for this episode. First question: imaging with which radiotracer classically will show renal activity? Technetium tagged white blood cell scans or indium tagged white blood cell scans? Which one of these classically shows physiologic renal activity? The answer is that technetium 99M tagged white blood cell scans show physiologic renal and GI activity, whereas indium tagged white blood cell scans classically have no physiologic renal or GI activity, or at least much less renal or GI activity compared to a technetium 99M tagged white blood cell scan. Therefore, if you see renal uptake on an indium tagged white blood cell scan, one differential consideration is pyelonephritis or other causes of renal inflammation, to include post-chemotherapy states. Given the GI activity that is seen on technetium but not indium white blood cell scans, at least to the same extent, indium is also the preferred agent in terms of nuclear medicine white blood cell scans for evaluation of bowel infection or inflammation, to include settings such as inflammatory bowel disease. Next question: if a technetium 99M MDP bone scan shows the renal cortex has more uptake than the osseous structures, what entities can be considered? The answer to this question is that with very robust renal cortical uptake on a bone scan, you should think of entities such as hemochromatosis, recent chemotherapy causing renal injury and inflammation, or urinary obstruction, to include other entities. Next question: how do things like horseshoe kidney or renal transplant present on a bone scan? What I am getting at here is that with both horseshoe kidney and renal transplantation, you may not see renal uptake in the expected location, and so you need to expect lack of renal uptake in the expected location. For horseshoe kidney or renal transplantation, look to see renal uptake in the pelvis. This can be a trap on a multiple choice question to try to get you to incorrectly assess the image as a superscan, which occurs when there is lack of renal and bladder uptake as well as soft tissue uptake on a bone scan due to diffuse osseous uptake in the setting of diffuse osseous metastatic disease. With horseshoe kidney and renal transplantation, assuming the renal function is adequate, you should have soft tissue uptake, unlike a superscan. Next question: what is the pattern of normal renal uptake when imaging with gallium-67? Gallium-67 shows normal renal uptake at 24 hours, but should not show robust renal uptake beyond 48 hours. Remember, with gallium-67, delayed imaging beyond 48 hours is possible due to the long half-life. If you see a gallium-67 scan with prominent renal uptake on imaging obtained at least 48 hours after injection, think of entities such as renal infection or inflammation. However, if you see this on a 24-hour scan, the renal uptake could simply be physiologic. Next question: What are differential considerations when you see prominent renal uptake on a sulfur colloid scan? Differential considerations for prominent renal uptake on a sulfur colloid scan include renal transplant rejection, pyelonephritis, congestive heart failure with reduced renal blood flow and filtration, and thrombotic processes to include disseminated intravascular coagulation, often simply called DIC, as well as thrombotic thrombocytopenia purpura, also abbreviated TTP. Those are all entities that can cause very prominent renal uptake on a sulfur colloid scan. Next, when considering technetium-99m mag3, technetium-99m DTPA, and technetium-99m glucoheptanate, which of these are filtered by the kidneys and which are secreted? It is very important to remember that technetium-99m mag3 is secreted and the other agents are filtered. Because technetium-99 mag3 is actively secreted and not passively filtered, it has better uptake and allows better assessment in individuals with renal failure. Next, are renal scintigraphy images standardly obtained from anterior or posterior projections? In general, and I know there can be certain exceptions, standard renal scintigraphy projections are obtained from the posterior view. Be cautious, therefore, when stating a finding is in the left or right kidney, because you need to realize you are visualizing the kidneys from a posterior view. So the right kidney is on your right side, which is opposite of usual radiology convention for imaging with things like CT or MRI. However, exceptions include anterior imaging that may be preferred for settings of pelvic kidneys, such as in renal transplantation or horseshoe kidney. Next, what are the 3 phases of imaging obtained during a MAG3 study? The 3 phases of imaging obtained during a MAG3 study are blood flow, followed by cortical phase, followed by clearance phase. Remember, with MAG3, you are looking for function more than anatomy. These various phases tell you a lot of specific information about the physiologic function of the kidneys, and we will get into more details of these phases on this and the subsequent episodes that discuss renal imaging for nuclear medicine. Next, what is the normal appearance of the kidney during the flow phase of a technetium-99m mag3 study? The normal renal appearance on a flow phase of a mag3 study is prompt aortic activity, essentially immediately after injection, which would be within 1 or so frames because you are imaging basically continually during the flow phase from injection onward. So you see very prompt aortic activity, quickly followed within only a few frames by renal artery uptake, followed by symmetric renal uptake. The flow phase tells you a lot about whether the kidney is adequately perfused, and you expect to see prompt, symmetric renal uptake following injection in the flow phase. Next, if you see asymmetric renal uptake on a MAG3 study in the flow phase, what are some of the top differential considerations? First, you need to consider if you see asymmetric renal uptake on a MAG3 study in the flow phase, thrombosis of the renal artery and or renal vein, in addition to chronic obstruction of the kidney with delayed uptake on one side, as well as things like acute rejection if it is a transplanted kidney, as well as acute renal infection. Note that if both kidneys show abnormal delayed uptake in the flow phase, this could be related to a weak radiotracer bolus versus entities such as chronic bilateral high-grade renal obstruction. Remember that if both kidneys show prompt uptake and one kidney shows asymmetric increased uptake while the other shows normal uptake, one differential consideration is renal artery aneurysm. Again, if both kidneys show prompt uptake in the flow phase, but subsequently one kidney shows asymmetrically increased uptake and the other kidney shows normal uptake, so it looks like one of the kidneys is getting more perfused than the other, but the other appears normal, one differential consideration is renal artery aneurysm, where you have the increased uptake due to the aneurysmal renal artery that may be projecting over the kidney. Next, true or false? Acute tubular necrosis presents with abnormal renal perfusion. The answer to this question is false, and this is a key concept. Acute tubular necrosis and interstitial nephritis have normal renal flow. The problem is not with the arterial system feeding blood to the kidneys, so these entities will show normal flow on a MAG3 study. Final question for this episode. True or false? Differential renal function is typically calculated from flow phase data on a MAG3 study. The answer to this question is also false. Differential function of the kidneys should be calculated based on the cortical phase data, and remember that is the second phase of a MAG3 study. So you start with the blood flow phase, followed by the cortical phase, and concluded by the clearance phase. And again, differential function of the kidneys should classically be calculated based on the cortical phase data. And the cortical phase is also sometimes termed the parenchymal phase. The cortical or parenchymal phase, which again is the same thing, is the phase where the kidney is doing its work of secreting and filtering substances from the blood. And this is the phase where calculating relative counts between the kidneys, which is a surrogate of renal function, can provide information about the differential function of the kidneys. To calculate the differential function, you place a region of interest around each kidney and have a corresponding region of interest for background correction. We may talk more about that later. You want to calculate cortical uptake, so the region of interest are drawn something like 1 minute after injection, so tracer has mostly left the blood and entered the renal cortex, but is mostly not yet in the renal collecting systems, meaning you want to image about the maximal cortical uptake phase, which is something like 1 minute after injection. A well-functioning kidney should have a steep uptake slope in the cortical phase to show it is able to uptake the radiotracer from the blood in a rapid manner. Thank you for listening to this episode. I hope some of these concepts are helpful for many of you. This episode discusses some basic concepts pertinent to renal imaging in nuclear medicine and focuses some attention on the flow and cortical uptake phases of a MAG3 study. The next episode will present concepts pertinent to the clearance phase of a MAG3 study and will discuss very important concepts pertaining to things like renal obstruction evaluation, renal artery stenosis, and renal transplant evaluation. Keep up the good work and study hard. Remember, you have to study really hard to succeed on radiology and nuclear medicine board exams. So prepare to succeed. I will catch you on the next episode. Content of this podcast is provided for informal educational purposes only for radiology trainees and radiologists. Medical practitioners, please make your own independent assessment before suggesting a diagnosis or recommending any course of treatment. This podcast should not be used for self-diagnosis or self-treatment and is not a substitute for independent professional medical care. Please consult your own physician regarding any diagnosis, imaging interpretation, or course of treatment.